Hello everyone, I'm Joel Balzon, and for my lessons learned from the Institute for Healthcare Improvement presentation, I will discuss PS 105, Responding to Adverse Events. For this presentation, I will cover 3 lessons consisting of a step-by-step approach in responding to an adverse event for Lesson 1. Lesson 2 will cover communication, apology, and resolution. And finally, the impact of adverse events on caregivers will be covered in Lesson 3. Here are the learning objectives for Lesson 1. So from this presentation, you should be able to describe the immediate steps caregivers should take when something goes wrong in a patient's care, explain the importance of communicating about adverse events and documenting them, and lastly, explain the importance of seeking answers after adverse events and near misses. Let's first define what an adverse event is. According to the Office of the Inspector General, an adverse event is an event, preventable or non-preventable, that caused harm to a patient as a result of medical care. This includes never events, hospital-acquired conditions, events that require life-sustaining intervention, and events that cause prolonged hospital stays, permanent harm, or death. The reality is that adverse events occur daily in healthcare, and at times they lead to patient harm. Knowing how to respond appropriately and effectively is important not only for the patient, but for the healthcare provider as well. There are 4 steps that healthcare providers should take in responding to an adverse event. These actions, which consist of providing care, communicating, reporting, and documenting, will be covered in this lesson. Taking these necessary steps in responding to an adverse event will help to restore safety for the patient at the center of the incident and set the stage to improve the safety of care for future patients. In responding to adverse events, the first step is to provide care. The patient is the first victim of an adverse event. It is the very first priority that you must ensure when something goes wrong. To provide care is to address the current healthcare needs of the patient by assessing the patient's condition and determining what, if anything, needs to be done immediately. This is to make certain that the patient's status is stable and that the patient is safe. The next step in the process is to communicate with the patient and the healthcare team. How is the communication delivered in response to an adverse event? So deciding exactly when and how to communicate with the patient after an adverse event takes good judgment and should be informed by organizational policy. It is also helpful to approach these decisions as a team and to assign a leader of the communications effort. In some cases, the care team may decide for medical reasons to defer communication with a patient about an upsetting incident, perhaps communicating initially with the family or an individual representing the patient. But if you try to conceal information or are dishonest, people will know. Good, effective communication promotes a trusting relationship. In communicating with patients for the first time after an adverse event, one should not place blame or make guesses. The initial goal of communicating is to acknowledge the event, express regret that it happened, and explain whatever you do know for certain and your intention to learn more. So right away, one can promote a trusting relationship by expressing compassion, making it clear that you intend to learn and share more what happened as soon as possible, and lastly, making it clear who will be available to help the patient and family. Reporting is the third step in responding to adverse events. So who do we report to? When an adverse event occurs, various people, departments, entities, or agencies will need to be notified, such as the physician responsible for the care of the patient, if not already involved, the risk manager, patient safety officer, or quality officer, the nurse manager for the ward, the CEO or chief executive, the board of directors, as well as the Department of Public Health. So what should we report? So we should report harm items, events, or adverse events, as well as near misses. Level of detail of the initial report should be kept simple, and the reporter's job should be as easy as possible. Although serious adverse events may get the most attention, it is important to recognize that every failure is an opportunity for learning and improvement. This includes near misses when the patient is not actually harmed. For prioritization, the organization's responsibility to understand the big picture and prioritize action. So when in doubt, you should report. The final step in responding to adverse events is documenting. Documentation is important for the patient's care and to help future investigators understand as much as possible about what took place. The medical record should contain a complete, accurate record of the clinical information pertaining to the adverse event. As applicable, the documentation should include objective details of the situation, written in neutral, non-judgmental language, the patient's condition immediately prior to the event, the intervention after the adverse event, as well as the patient's response, and notification of the primary care physician and attending physician, as well as the information shared with the patient or patient's representative following the event. Moving forward, Lesson 2 will cover communication, apology, and resolution. The 3 learning objectives are to list 3 guiding principles for sharing bad news with patients, to explain the importance of apologizing after something goes wrong, and to describe the structure and content of the effective apology. Although communicating is an essential process in responding to adverse events, not all healthcare providers do it. It is known that stepping up, taking ownership, and communicating about events after something goes wrong is not easy. Reasons for not communicating when something bad happens includes a psychological need to preserve a sense of self, fear of admitting responsibility for making an error that may have hurt someone, fear of anger from the person, patient, or someone in authority, fear of loss of job or position, threat of censure, threat of medical malpractice claims, fear of colleague disapproval, and fear of negative publicity. These are normal fears to experience after an error occurs. One way to help overcome them is to have a plan of action. Deciding when and how to communicate with a patient and family after an adverse event takes good judgment. Here are 3 guiding principles. 1. Communication is necessary when an adverse event causes harm or significant intervention is required to prevent harm. It may make sense to defer communication when the care team feels that, for medical reasons, it is not the patient's best interest to know about an adverse event immediately. And lastly, communication is usually not necessary when there is a near miss that does not harm the patient. So how do you communicate bad news to the patient and the patient's family when an adverse event happens? This is done by using open and direct communication after such an event, which includes apologizing. This is a good way a healthcare provider can hone his or her skills for a time when the individual may need to respond to a more serious adverse event. When communicating bad news, it is important to speak clearly, slowly, and directly. Pause often to allow the listeners to collect their thoughts. If the news is very bad, the patient and the family may find it especially difficult to process the complex information. As the initial shock wears off, patients and families are better able to listen and evaluate what they are hearing. Because most health professionals are not trained in this type of conversation, clinical leaders should encourage training and practice using different scenarios. After an adverse event, a genuine apology helps to restore the patient's dignity and begin the emotional healing process for both the patient and the staff member involved. Often the apology should be a joint effort. For example, the person who made the error and an attending physician could meet with the patient together. So why is apologizing important then? Apologizing provides many healing mechanisms such as the restoration of self-respect and dignity, feeling cared for, restoration of power, suffering on the offender, validation that the offense occurred, designation of fault, assurance of shared values, entering into a dialogue, reparations, and a promise for the future. Now let's look at the structure of an apology. As you can see, it consists of 4 components along with statement examples following each one. The first is acknowledgement. This should include the identity of the participant, appropriate details of the event, and validation that the behavior was unacceptable. Next is explanation. The speaker must provide an honest reason for what happened and accept responsibility, making it clear the patient did not do anything wrong. Sometimes saying, "there's just no excuse for what happened," can be the most honest and dignified explanation. The next component is the expression of remorse, shame, and humility. In this context, remorse is a deep sense of regret. Shame is the emotion associated with failing to live up to one's standards. Humility is acknowledging your own limitations and flaws as a human being. Lastly, there is reparation. How will providers make amends for the wrong? Reparation can range from an early scheduling of the next appointment to a financial settlement. Patients want to know that they are cared for and also that the problem will not happen again. In addition to wanting the truth, patients want to know that you will not abandon them. A first step towards making amends after an adverse event is to make yourself or someone who can help available to the patient and family. The goal is to support the patient and family during this critical time. The last lesson discusses the impact of adverse events on caregivers who are considered the second victim. Below are the learning objectives, which are to explain the concept of the second victim in healthcare, describe the impact of adverse events on providers, including what they may feel and what they may need, describe barriers to second victims getting the support they need, and list resources that are available to support caregivers after adverse events. As mentioned earlier, the patient is the first victim of an adverse event. Here, we have to focus on the caregiver or healthcare provider as the second victim after the occurrence of an adverse event. Caregivers do not intend to harm patients and can suffer from psychological effects stemming from these adverse events, such as depression, increased stress, anxiety, or loss of self-confidence or self-esteem. One story that was shared in the course was a pediatric nurse who unfortunately took her own life because of an adverse event that occurred while caring for her patient. So it is important to acknowledge that caregivers are victims too. Fundamental attribution error is the assigning of disproportionate blame to the individuals involved in an adverse event, rather than apportioning responsibility appropriately between the individuals and the organization. It is a common mistake that has serious consequences for individuals and organizations, such as stifling transparency and learning. If you find yourself involved in gossip about a colleague's involvement in an adverse event, a formal committee whose responsibility is to evaluate blame, or an error that you're worried is all your fault because it isn't, make sure you keep the fundamental attribution error in mind. This slide covers the important needs of the second victim, the caregiver. The type of support the caregiver typically asks for includes early identification of suffering, ongoing emotional support from peers, gossip control, and the opportunity to be part of the improvement efforts related to the event. The affected caregiver usually looks for support from family, peers, supervisor, as well as their higher organizational leadership. Regardless of the severity of the event or provider's feeling about it, the reactions from these people can make the situation better or worse. Their response can mitigate or propagate the sense of isolation or shame. Despite the need and desire to support in the aftermath of an event, caregivers often cannot or do not take advantage of support services, even when they are available. Researchers found that providers reported the following barriers to seeking emotional help after an adverse event in which they were involved. These are difficulty taking off work to engage in counseling, feeling that the counseling would not be helpful, concern that statements during a counseling session would not be kept confidential and serve as evidence if they were sued, concern that their counseling history would be recorded in their permanent record, concern that receiving counseling could drastically affect their malpractice insurance costs, and concern that they would be judged and labeled negatively by their peers. And finally, this slide indicates some great resources that are available to support clinicians after medical error and to help hospitals improve their support systems. Caregivers involved in adverse events should accept that they are also harmed by the event and may need support and help to address their pain. In closing, I would like to say that we are all humans and we will eventually make mistakes along the way while practicing our profession. I hope that just in case anyone gets involved in any adverse event, you will take advantage of these resources within your organization and seek out ways to understand and address your feelings. Motivate your teammates to also do the same. These are my references, and this concludes my presentation. Thank you.